Just below the skull base on the patient's right side is actually the infraorbital rim. So it's displaced lateral to the mandible. This patient also had a mandibular fracture. There was a symphysis and an angle fracture. And what we're looking at on the right side is that's orbital fat. The soft tissue that's pink up top is the inside of the eyelid, right? And then the hemostat illustrates Stenson's duct, right? So the duct is intact. That's good. That means we don't have to repair it. And that's a lateral probe in the duct showing that it's intact. So as things turn out, not quite as bad as it looked initially, right? And this kid did really well afterwards. This also wasn't one of my cases, one of my colleagues from Indiana University when we were out there. But this kid did remarkably well. Remember what I said about soft tissue injuries, that little triangle piece on the cheek that's dusky. In an adult, that might not survive. In a kid, it probably will. And it did in this case. So the kid did very well afterwards. There was no injury to the globe, so the vision was not disrupted at all, and the patient did fine. So also another zygomatical maxillary complex fracture, and you see there's bruising around the eye. There's on the image on the right, there's the incision line marked. When you do a tripod, I said we can do a semi-open, and this illustrates that. You make an incision in the brow, and you can slide this instrument behind and move that bone forward. The incision in the lower eyelid, it will then be used to span the gap of the fracture of the orbital rim. And we can see that move under direct vision as you have that instrument up in the brow, moving the segments forward. These can be done with wire. They can be done with plates. It's particularly helpful if you have an area when you reposition the bones, there's a segment missing, because sometimes these bone segments are so tiny that you can't reapproximate them. And a bone plate in a situation like this is very helpful because it can span a gap, hold those segments apart. You can put bone graft material in there if you desire, but usually this will heal without any difficulty. And even mesh can be used in the orbit. This was a patient that was having a reconstruction after a gunshot wound. And the mesh will work as well as anything else. The incisions heal nicely without a lot of problem. This is what it looks like on the left side immediately post-op. This is a typical outcome after the incision if you make it in the lid. You can also go through the conjunctiva on the inner side of the lid. That restricts your mobility a little bit and your access a little bit. But these skin incisions are so nice that there's really not much reason to be concerned about scarring. Now remember, if a patient who gets eyelid surgery for cosmetic purposes, this is the same incision that's used to do that. Nobody ever complains about those because they heal so nicely. Nasoorbital ethmoid may involve the medial canthi, which means that the normal almond-shaped eye will change. It'll be much rounder. We'll illustrate that in a minute. You need to consider nasolacrimal drainage because the frontal sinuses may not be able to drain if that nasolacrimal duct is disrupted. And oftentimes you need revision surgery afterwards because the bones are so thin here and they're often in such tiny pieces that it's pretty hard to get things back together primarily. So here's a situation. This is definitely a nasoorbital ethmoid. What you're looking at is the turbinates in the nose. That's the tip of his nose down toward the left of the field. This was an old case back from when I was a resident. The globe is not there, as you can see. This guy was already blind in that eye, so it wasn't a concern. But as you can imagine, there wasn't a piece of bone bigger than a millimeter left in this guy's face. So it's pretty hard to get things back together. Got to manage the soft tissue issues and then go back and do revision surgery after things heal. You can get avulsion injuries with these kind of things. They're often associated with gunshots. If the avulsed parts are salvageable and they're big enough and or they have a blood supply, you may be able to reattach them. Probably in a situation like this where you have an isolated nose, it's likely to fail, and you're probably not going to be able to do it. The patient's going to wind up with a prosthesis at some point. So this is a fairly common nasal-orbital ethmoid type injury. This was actually a race boat injury. This guy was ejected from a boat and got hit from a boat behind him. You look at his eyes, you see his right eye is normal contour, his left eye is rounded. Right? You also look at his nose, he's got a depressed nasal bridge. And that's a situation that goes along with nasal orbital ethmoid fractures. In this guy's case, the primary goal, this was an injury that was several weeks old. So the nose is probably going to be something that gets revised later. But in the short haul, we want to get the eye back in the right position. So we want to get that medial canthus tied back to the nasal bones. So in this case, just some small incisions. You find the canthal ligament, take a wire, put it through, pass to the other side, turn around, bring it back, and then tie it down. So as we twist this wire down, it will pull the medial canthus back in a more normal position. So, in summary, our clinical examination guides imaging. Imaging almost always in these cases nowadays, though, will be CT scans. Got to have adequate imaging to do your surgical planning. But even with appropriate surgical management, you may need to do revision surgery on these patients. Patients play a role in their recovery as well. Many patients ignore instructions. They don't come back for follow-up. They don't let us fix things before they become problems. So we need cooperation of the patient as well. These can be serious injuries, but they almost always can be treated so that you get a pretty good outcome. So this will be my last lecture for this course. Dr. Markowitz and Dr. Cronin have lectures to go still. I'm not sure how they're going to present them, but we will keep you posted. Anyone with questions about this or any of the other material that I've covered so far in the course, please feel free to email me, jc294@buffalo.edu, and I'll be happy to answer them for you. And if there are significant enough questions, I can respond to the whole class.